Wonderful. That was really an outstanding lecture you gave, and we're all very excited about this glove. And there's a record number of questions that were submitted. There was so much interest in this topic. So my job is to filter some of these questions, as there's really too much, for the remaining part of the webinar or the seminar. So I'm going to focus on some of the more common questions that were asked. Well, I guess the biggest question was, where are you now in the research for this, and are there trials going on?
Yeah, well, as I said, we are just finalizing the development of a next generation glove system that, based on everything we know about physiology, about pathophysiology of Parkinson, about physiology of proprioception, meaning the sense of touch, and about neuromodulation, should be a clear improvement. And then we have a clear clinical development strategy that should lead us as soon as possible, some like early or autumn, spring next year, to an FDA approval trial. Depending on the response times of the new glove treatment, the FDA approval trial will have different outcome times, visit times. But nonetheless, our goal, I'm working with really world-class people. Now I'm very fortunate about this. The overall goal is to bring it to all patients as soon as possible, to get reimbursement for this, to make it to a treatment for just a few out-of-pocket payers or so, but to really bring it to all patients in the US ASAP. And I'm very confident that I have the right partners now, and we hope to do this within, this is just a rough, and please, it cannot promise precise timelines, but I hope within 2 years or something like that from now.
And do you foresee that the trials will be eventually done in multiple centers in the US or even outside of the US?
Yeah, well, we'll do some core development studies that are relevant in order to better understand the impact of, for example, vibration and on the brain. And there are many of such studies, but I wouldn't call them trials, that will be performed at Stanford. And then we'll do, for example, the FDA approval trial, the pivotal trial would be multi-center, might also have a European side, but we'll definitely want to spread this also on the study phase, not restrict this to Stanford, but collaborate with other experienced centers.
Wonderful. And then in terms of its compatibility with deep brain stimulation, so there's many devices out there, like for instance, there's a tremor device, and these devices which are out there are usually not compatible with patients that have had DBS or deep brain stimulation. So do you foresee that this device can work hand in hand with DBS?
Yeah, well, we are planning this device is not meant to be as a competitor to DBS. Future will tell what is the role of this device, what is the role of DBS, and their interaction. So there are no negative feelings against DBS, by far not. I'm in a neurosurgery department. I've spent quite some time in my life to improve deep brain stimulation and so on. But the important point is we are planning studies in patients, DBS patients, but also post-surgery patients, non-DBS patients, for example, after ultrasound treatment, who do not have the right sufficient benefit and want to enroll these patients too. We want to see whether these patients can benefit from it, but I cannot promise anything. Time will tell. But the other thing is we have to certainly take into account that over time also structural connectivity in the brain changes under DBS. So it's not something we should take for granted, but we'll thoroughly test this. And the ultimate goal, by the way, is one of our ultimate goals is, in particular, that we've seen that non-motor effects also respond to this treatment. And it's not just olfaction, it's also vision. I had, for example, one patient had a huge improvement of gait and balance. And next morning he came in, he was still off medication and doing so well. But he said most striking thing for him, although he recognizes that his gait is so fabulously improved, most striking thing is that all the colors are stronger and everything's brighter. It's like this dopa honeymoon effect on vision. And we know that there are a couple of things, and we can measure this in a very easy way by, for example, latencies of evoked responses to checkerboard type of patterns and things like that. We'll study this too. And the ultimate goal will be to provide patients already in a very early stage with a treatment that helps to hopefully slow progression.
Yeah, I'm very happy to hear that, you know, at least in what you presented, that this potentially can impact the non-motor symptoms. Have you seen, of course you dabble in deep brain stimulation as well, but have you seen improvement of sense of smell and taste in your DBS patients?
No, we haven't. We've only stimulated for a few hours, for a few days. There was one patient who was staying in the hospital for up to 2 weeks, and he had a fabulous improvement, no tremor, even after at the end when he was dismissed. But we had to turn, upon dismissal, all the patients had to receive standard DBS. So at that time, we do not yet have chronic DBS. See our coordinated reset DBS data. This is something we want to do together with Boston Scientific soon.
And then the effect on freezing is just remarkable from those videos. So if there is a Waterloo for DBS, it's freezing of gait. So whenever I see patients that come to my office and say, is there any hope for my freezing of gait? And kind of say, well, deep brain stimulation will help the off freezing. In other words, freezing that can occur both in the off and on states. And I kind of say, okay, if the freezing improves with your medications, then DBS potentially can help your freezing. But if you're still frozen in the on state, then I kind of tell my patients, okay, most likely DBS will not help the on freezing. So the videos that you showed us were patients that obviously turned on, right? Switched on with the vibration glove. But the question is, will this also potentially help the on freezing?
I think so, because we had patients with on freezing. But I mean, still the number of patients is too small. This has to be thoroughly studied. But so far, all of these actual symptoms appear to respond well. Also, voice was a typical symptom that responded really well. So, for example, we had patients that came in, and it was really hard to understand them. Next day in the morning, their voice massively improved. And there was one patient, for example, from the East Coast. He had talked to his family in the morning over the phone, and they were able to properly understand him. They were totally surprised. So voice impairment is also fortunately an early symptom. We didn't expect this. Therefore, we didn't have a test battery or a test set up. There are simple setups. We are working here with Elizabeth DiRenzo. She works in that field. She's good. She's really good. And in the upcoming studies, we'll test voice so that we can objectively or in a proper way demonstrate improvement.
And then the patient videos that you showed were mostly young patients. And again, you know, one of the things that may screen out a patient for eligibility for deep brain stimulation is advanced age. For instance, you know, at least in my practice, I still am able to include patients that are kind of in the elderly age group for DBS, as long as cognitively they're okay. But do you think the glove will have the same effect on older patients with Parkinson's, those with more advanced Parkinson's, and are old?
Yeah, we have a couple of patients that were 85 plus, and they responded well. So it's the video, the selection of the videos, or the patients who gave permission to share their videos with the world didn't respond the characteristics of our patient population with respect to age, but also with respect to gender. We also had women that had beautiful responses. So it was not only men.
And then, most patients, whenever we propose interventions which are surgical or more invasive, the first question they ask me is, what are the side effects? What can I expect? So with the glove, if this is used presumably 2 hours per day, what are the side effects, short-term and long-term, potentially?
Yeah, it's a very, very important question. We haven't observed any side effects, fortunately. What we observed is something of, I think it's not strictly a side effect, but there's one thing one has to take into account. In patients with LID levodopa-induced dyskinesia, in all patients, the glove replaced, so to speak. We do not yet probably understand how this works, but replaced dopa to some extent. We'll do studies on this mechanism of action studies also in patients. And in the LID, the levodopa-induced dyskinesia patients, what we've seen is the following. Those patients have to either reduce their medication when they start using the glove, or we start with the glove at a lower dose, some like only maximum 2 hours a day, and then ramp it up within the first 3 weeks, and then in parallel decrease the medication. Because if we go in with we start with high glove dosage, the dyskinesia is increased. But patients also, for example, the patient with the turban on the videos, he had super pronounced dyskinesias, and he's really doing well. So long term, the dyskinesia appears to respond based on, of course, the limited population we have so far, responds well to the glove.
So are you saying that the dyskinesias can potentially improve directly from the stimulation, or is that by virtue of the fact that many patients after DBS or after the glove, hopefully, their medication doses are reduced, if not completely eliminated?
Yeah, this is something I cannot yet make a clear claim or clear statement, simply because we have patients who had a massive reduction of medication due to the glove, and hence no dyskinesias anymore. But we also had a patient, for example, it's n equal to 1, it's not enough, who didn't reduce his medication, but the dyskinesias went away, vanished. But it's not enough. It's not enough to make a clear claim, of course. This has to be properly studied in the future.
Now, given that the glove is put on in 4 fingers, what happens to patients with neuropathy, bad neuropathy, or perhaps carpal tunnel? Will this thing still benefit those type of patients?
Yeah, that's a very good point. I mean, it's not, and this is not meant to be in any way negative or so, and I think you know this, but it's not the highest priority, but we are planning a study for patients to be treated with a glove that do have sensory impairment. There are different types of sensory impairment. You mentioned neuropathy and so on. And one option certainly is unilateral stimulation. We do have a few patients who were stimulated only unilaterally. And if you recall, for example, our coordinated reset deep brain stimulation studies in humans, they were done unilaterally. And we had full-blown effects. And we'll do everything in order to reduce the burden for the patient. Both unilateral stimulation might be superior, of course, but also reducing the duration. We have clear plans, also clinical development plans, and also the new device, I think, will massively help with this.
Yeah, and are you also planning on doing, let's say, neuropsychology tests before and after, and see whether this might have a meaningful impact, on their cognitive faculties? Yeah,
absolutely. I mean, super well how that the spectrum of cognitive impairment in Parkinson's is even broader and more complex than the motor spectrum in a way. And therefore don't want to make any claim. What we've seen so far is that in a few patients that the glove really helped them massively with respect to their cognitive impairment. I don't want to make any claim about this. This has to be properly studied, systematically evaluated. And we will, of course, in the upcoming trials, use these questionnaires and these tests. And later on, also we'll do specific studies also in patients with cognitive impairment.
So the glove is put on presumably 2 hours per day, but is more better? How did you come up with 2 hours?
Well, it's we also have a sensory stimulation for tinnitus, and the important point is, and I'm working on vibrotaxis stimulation for quite a while. I didn't have the right device or a robust device, and the experience was it takes something like half an hour until you recognize that rigidity decreases, and the 2 hours were on the more conservative side, in the sense probably it's not necessary to stimulate that much, but when you start with trials or with studies, you want to make sure, in particular, since there are no side effects, practically no side effects, you want to make sure that you have a sufficiently large effect size.
Yeah, like for instance, with DBS, we can adjust the stimulation parameters. So the more symptoms they have, the more severe the shuffling, the more severe the bradykinesia, the more severe the tremors, then we kind of say, okay, we're going to introduce more electricity. So I guess, would you foresee that there will be like a dosing of the amount of time for this to improve their symptoms?
Yeah, definitely. And from a very fundamental perspective, the new glove system will take into account and will deliver personalized treatment. It will be calibrated to each individual patient, and then also on the midterm level, we will also monitor effects. Also in our first studies, we'll monitor the effects of the glove on symptoms, and then of course we'll close the loop and adapt the stimulation duration, but not only the stimulation duration, but also other specific features of the stimulus parameters. And
then while the stimulation is ongoing, and they have the glove on, what exactly will they feel in their hands or in their body? What do they feel any sensory symptoms or tingling or numbness or whatnot?
No, it's the stimulation is quite weak. So it's not painful, it's not strong, it doesn't perturb you when you, for example, want to read a newspaper or want to read something, or want to work on the laptop or something like that, or when you're on the phone. It's very weak, or our patients also went for a walk or were jogging with it or so after a while. And it is typically, and this is something we'll study also systematically. We wanted to do this during the COVID time, but we'll start hopefully this autumn also with this study in also healthy subjects to better understand it in a very systematic manner. The glove often has is either neutral, or in many patients, or in also many healthy subjects, causes a Zen type of effect, meaning it's relaxing. Doesn't make you tired, but it relaxes you. And patients, our patients, the huge majority of patients in our pilots so far, they reported that they love this immediate relaxing type of effect of the glove.
Wonderful. If the audience has any, if there are questions from the audience, I think we have microphones, so we can also, ask live questions aside from those that were submitted online. Go ahead.
I didn't catch the interval we had in the glove. You said twice a day. How long in between? 2 hours to 12 hours?
Do you mean the pause in between?
How many times per day will they have to use it?
How many times? At the beginning, well, in our pilot studies was 2 times 2 hours a day, with a pause of at least 1 hour in between. In the new studies, we'll do something like 2 times 2 hours, in total 4 hours per day during the first few weeks. And then it'll be reduced, because that's our experience. Patients do not need that much dosage. That's one thing. And the second thing is we expect the new glove to be way more effective. And therefore we will start also with a bit more dosage type of pilot studies where we see the response time. And then from there we go with a couple of controlled studies and then pivotal study.
How do you account for the cumulative effect? I mean, there's an acute effect, and yet there's a cumulative effect. So what exactly is happening in the brain that can account for this cumulative effect?
Yeah, it's a very good question. I mean, what we want, what's known from Parkinson's disease is that on a micro, but also on a macro level, anatomical level, there are structural changes, connectivity changes. That's very well understood. And we want to counteract these structural changes and just to revert them as much as possible by normalizing the activity. That's one aspect. So what we'd expect is that we have, and this is something that we are going to study in one of our mechanisms of action studies in patients. We want to see what are the macroanatomical changes, for example, detected by means of DTI. And the other thing is, if you think, for example, of mechanisms like excitotoxicity, neurons that are massively and overly active all the time, they may get into a metabolic exhaustion and die or stop dopamine production. And that's the other thing. I mean, for example, in the group by Jens Volkmann, they've shown, for example, in rats, in a disease model of rats, that if you these rats, they deteriorated, so their motor score increased, their symptoms increased over time. And what was done in these rats, that in a very early stage, STN DBS was delivered, very, very early stage, to prevent the neurons from firing in this abnormal way. And this reverted the progression. But of course, I mean, DBS, we cannot deliver DBS at very, very early stages. And of course, not to all patients, because these DBS is restricted to special clinics or special surgeons. And but that's our goal, you see. Our goal would be to provide patients at these very early stages with this non-invasive intervention to hopefully decrease disease progression.
Wonderful. Okay, there's a question from, wonderful. Go ahead.
Hello, Dr. Tass. My name is David Raffelli, and it's nice to finally meet you. We have several connections. I got to work with your team last year at Stanford, and I actually got fitted for the glove, and I look forward to continuing this fall. I'm also a patient of Dr. Dahl's in University of Arkansas. Mm-hmm. And as a physicist, I teach a physics class. How would you describe dynamic self-organization to my physics class? Thank you.
Yeah, thanks. Nice to meeting you. Well, I think dynamic self-organization is basically a process where there's not just one master unit that dictates the behavior of all other units, but the system, by, for example, unspecific changes, the system gets into ordered state of high complexity without there being something like a boss telling them what they have to do. And by the way, one of the first, just as a side remark, and perhaps this illustrates this, just as a side remark, one of the first publications, experimental publications on this was the Lousov-Sabotinsky reaction. So in the Petri dish, if you don't steer, you see beautiful spiral waves emerging. And it was, I think, in 1903, beginning of the last century, when this paper was submitted, and it was rejected at that time. And the reason was, it's impossible that such beautiful and highly ordered structures emerge without anybody controlling it. You see, and one of the areas in which self-organization was really super well studied was laser physics, because the interesting thing about the laser is you have to sort of pump energy into the laser, and if you're below a certain threshold, you have incoherent laser light, no order. And then you, like if you increase a heater, the temperature increase, and then you pump more energy into it. And if you exceed a certain threshold, you have this beautiful laser light, the miles and miles long pure sine wave.
Okay, and then there's a similar device that I think it's being researched in the UK. It's called the Q1. So it works through vibration also. It's like a disc, a circular disc that's put in the chest. Have you heard of this, and how does it compare to the glove?
Yeah, I've heard of it. I don't know exactly. I have to be honest, I don't know exactly how it works. I mean, what actually is delivered, whether it attempts to cue or make help patients with rhythmic movements, and therefore cannot comment a lot on this, unfortunately. I don't know precisely how it works.
Got it. Okay. And then was there a question? Yes, go ahead, please.
Yeah, 240 hertz is the low frequency. Is it the amplitude and the frequency that causes the vibrations, or what is it actually motorized, or what?
No, it's the 250 hertz is the frequency of the so-called intra-burst frequency. So the system starts and delivers a 250 hertz burst, and then it stops. The important thing is less the specific frequency, but it is the pattern with which we deliver these bursts at different times, at different sites, that disrupt the abnormal brain synchrony.
You know, one of the things that will make a patient with Parkinsonism ineligible for DBS would be, you know, a diagnosis of atypical Parkinsonism. And really, this set of patients are really crying for help because the levodopa or the Parkinson's medicines don't help. And then when they ask for deep brain stimulation, almost all centers will say, nope, we're not going to do you because you don't have Parkinson's disease and you don't have levodopa responsive Parkinsonism. So would you foresee that the glove may potentially be of use to patients, let's say, with multiple system atrophy, progressive supranuclear palsy, perhaps dementia with Lewy bodies, and so on and so forth?
Can't tell you at the moment. We'll definitely try, but I unfortunately I can't tell you at the moment because we haven't tried so far.
Right. And then what about patients with essential tremor? Do you foresee that this may also benefit patients with essential tremor?
Yeah, I think essential tremors, and that's something we'll test soon. Essential tremor should definitely be a candidate, favorable candidate for this type of approach.
And I think one of the first videos you showed, that lady also had some dystonia of the hand, right? So that begs the question, will this potentially be researched as well for patients with focal dystonia?
Absolutely. Dystonia is the pathophysiology of dystonia fits very nicely to this treatment concept, as also does, by the way, epilepsy. And we have some, we'll start also in epilepsy patients, and we have some results, but dystonia should also be definitely a good application area for this.
Okay, questions from the audience.
How does one get into one of your clinical trials?
There is, we have, for example, on my lab's website, there's a REDCap link. REDCap is a secure way of communicating to make sure your data is securely handled. Stanford is very strict about this, and it's good. So, and there can fill out an electronic screening form. And then, since we'll run a couple of studies and trials, you might potentially not qualify for the first one, but for a specific other one then. So you might fill out this form, and then as soon as you're ready and you'd qualify, the team would contact you.
Okay, another question, please.
Yes. Do you need to be alert for this to be effective, or can you be asleep?
Did I understand you correctly? Whether one could also use the glove while sleeping? So
Yes.
Okay, thanks. Sorry. So what we did was the following: we instructed our patients not to use the glove at sleep while sleeping, simply because it's more difficult to control, and it adds more complexity to the study. Simply because the device we had at that time, we weren't sure whether, for example, the tactors, the stimulators might slip off or whatever. That's one thing. And the other thing is also stimulation effects might depend on sleep stages. We will study this in the future in a systematic way. We are preparing for this. The other thing is some of our patients, for example, said they loved to take a nap during the day. So they didn't use it at night, but they loved to take a nap and use the glove, and highly had a huge benefit from it. But this is just anecdotal, so we did not yet study this systematically.
Okay, question from the back.
Yes, I was wondering, would this also present positive effects for other symptoms of Parkinson's, such as the soft voice, choking, rigid body or posture? Does it help with those types of symptoms as well?
Well, on the one hand, all the motor symptoms and all the different subscores, tremors subscore, for example, and all these motor symptoms fortunately responded. And in particular, also the so-called axial symptoms, meaning gait, balance issues, also voice. In all our patients who had voice impairment, they had a significant improvement. Peggy Hamilton raised her hand. She's in the Zoom room.
Oh, well, I think everyone is muted. Maybe Peggy can submit her question in the chat box so we can read that. Okay, yeah, wonderful. Okay, other questions from the audience? Now, what about tolerance with long-term stimulation? So one of the things that some of our patients with what I consider as brittle Parkinson's develop a tolerance, and we sometimes have frequent flyers to my office. They're literally there every week, reprogramming their DVS because they're good for a day or two, and then their tremor comes back or some other symptom comes back. So do you foresee that there'll be tolerance, with chronic vibrotactile stimulation?
Yeah, I mean, the number of patients that we've stimulated for a long period of time, meaning more than a year and up to 5 years, is not that large so far. But we haven't seen anything like that, what you described, fortunately. So patients typically don't use the glove, don't need to use the glove. After 6 to 9 months of stimulation, the need for the glove usage is very low. It is something 1 to, in some cases, 3 times a week, 2 hours. 1 to 2 or 1 to 3 times 2 hours per week. So not much, considerably less than at the beginning. And patients even further improve. We haven't seen a case where a patient then got worse while using the glove. And even those patients, the 3 patients that had to return, that we were able to follow up, as I told you, that due to COVID, we had to stop this pilot in an early stage, but we were able to remotely follow up 3 patients, and they were stimulating for 6 months high dose, 1 month pre-planned pause, 6 month low dose. And then they had after effects, meaning they were in this, based on the motor scores, hugely improved condition, and massively reduced also meds for between 1 and 1.5 years. So we never observed any relapse or any adaptation or maladaptation to the stimulation, fortunately.
And there's a question from the chat. Can this help patients with Parkinson's that are not yet on medications? Can it take the place of medication?
You see, I don't want to make any premature claims or whatever. I mean, our goal would be to ultimately provide patients in very early stages. But it's not a competition. We don't want to fight against pharma or fight against medication. The most important point is the well-being of the patient. So the patients should feel as well as possible. And I think also the combination between medication and glove will be very beneficial for patients, because that's our experience. Patients came to us, and many of our candidates were DBS candidates. Many of our patients were DBS candidates, but we also had patients that were not the typical DBS candidates, but had suffered from side effects. But due to the glove, they got rid of the side effects. And I think there could be also very nice collaboration, so to speak, collaborative effort between medication and glove.
So where do you foresee that this will fit into the paradigm of treatment for Parkinson's? For instance, DBS usually we reserve for patients with more advanced Parkinson's, have exhausted the medical options, or some of my patients earn an earlier ticket to DBS if they're not tolerant of any of the Parkinson's medicines and they have, very bothersome tremors or other symptoms of Parkinsonism. So where do you think this will fit in that paradigm?
Well, I can, of course, based on the studies we've done so far, cannot make any claims, any strict claims or solid claims or so. Our goal is to help all of them, early and late stage patients, also patients who already have DBS, but are not content and, for example, do not respond well with respect to the shuffling or to the balance or things like that. But one of the ultimate goals is certainly to provide patients at a very early stage and hopefully to reduce disease progression.
Wow, that's really exciting. And then there's a question about focused ultrasound. Given that the stimulation entry point to the brain is the thalamus, so if a patient has undergone focused ultrasound thalamotomy, do you think this thing can work?
I would think so. I mean, at least if the patient has a sense of touch after the thalamotomy, but that should be the case. You see, patients still have sensory processing. I mean, this procedure, the surgical procedure, is very precise, and you do not destroy central hubs for proprioceptive processing. Therefore, I think yes. At least, of course, I cannot yet prove it, but we have an IRB ready for this, an IRB and protocol ready for this.
Wonderful. Okay, I think we're running out of time, so last call for questions, a brief one.
Dr. Tass, I was wondering how effective is this with total body dyskinesia?
Okay, how will this affect total body dyskinesia?
You mean in Parkinson patients or in general?
Parkinson's with levodopa dyskinesia.
Yeah, well, so far our experience so far is that that it was very effective, but it was a small N. We had patients who had very pronounced whole body dyskinesia, Parkinson patients, and they had a huge benefit.